now that we've completed cardiovascular, we're going to move on to hematology. And this is a very important, short, clinical subject. First off, we'll remind you of how to estimate our TBV, our total blood volume. This is a review. We originally learned how to do this on page C3. Your total blood volume is approximately 8% of your body weight expressed in kilograms. Using our reference person, the 70 kilogram, 154 pound young adult guy, 0.08, which is 8%, times 70 is 5.6. That means that of the 70 kilograms, 5.6 kilograms is blood. And since we know there's a one-to-one relationship between volume and weight, that a kilogram of fluid by weight has a volume of 1 liter, so therefore he has about 5.6 liters of blood. Incidentally, as a way of visualizing the amount of blood in your body, you'll notice I wrote this. We've all seen those 2-liter bottles of Coke or Diet Coke. So just imagine 1, 2 1/2 of those bottles. That's the blood volume. So if we took all the blood in a person's body, it basically would fill about 2 1/2 of those 2-liter bottles. That's 5.66, approximately 5 1/2. Okay, now what is a hematocrit, or percent packed cell volume, percent PCV? Some of you may have heard of a hematocrit before. Let's turn to the next page, page 2. And on page 2, if we were to take some blood from somebody, take a sample of blood, and spin it in a centrifuge. Now, when you have different substances in a solution, and you spin it in a centrifuge, in a circle, the heavier, more dense things are pulled to the bottom, and the lighter, less dense things rise to the top. So that actually will separate the blood into 2 components. The heavier cells are pulled to the bottom, and the lighter plasma, which is just basically mostly water, rises to the top. Now, when we look at this, the blood cells typically will make up about 45%, a little bit less than half, of the blood volume. So normally, the blood cells make up about 45% of the blood volume. That's called the hematocrit, or percent packed cell volume, because the cells have been packed to the bottom. Now, most of those blood cells are red blood cells. There is much fewer of our white blood cells and blood platelets. They make up a very thin layer right here, just above the red blood cells, called the buffy coat. And the buffy coat is called that because it kind of looks kind of whitish, and those are the white blood cells and platelets. They are included in the hematocrit of 45%. Now, if the blood cells make up 45% of our blood volume, then the plasma would make up the remaining 55%, right? 100% minus the hematocrit, which is 45%, is the percent plasma makes up, which is 55%. Let's look at the tubes right here, right below. This shows 3 hematocrit tubes. They're usually really very thin tubes, and you fill them with blood, and you spin them. So here it shows what's labeled a normal hematocrit. These are the percents here on the right. And if we read this, can everybody see that the blood cells make up about 45% of that volume? All right, just reading it on the right. So that's a normal hematocrit, or percent packed cell volume, PCV. Now, they did, this shows a hematocrit of a patient who's identified as being anemic. We can see that. We would say they're anemic based on the hematocrit. Because what is this person's hematocrit? How would you read that? What is it approximately? About 15%. That's extreme anemia. If the blood cells are supposed to make up 45% of your blood, and in this case the blood cells are making up about 15%, clearly that's very much anemic. And so that's one of the measurements they make to describe whether you're anemic. There are several measurements they make, and that's one of them. Simply saying your blood cells make up too small of a proportion of your total blood volume. On the other hand, here's a hematocrit tube, and what's the hematocrit on this tube? What does it show? 65%. 65%. Can you read that? So that's higher than normal, because normal is 45%. And in case there's any doubt, if you're thinking, what, should we know what normal is? 100% you should know. So this is called polycythemia. Poly means many, cyte means cells, emia means in the blood. Many cells in the blood. That's literally, I mean, clinical words, if you understand Greek and Latin roots, they pretty much mean what the Greek and Latin roots say. So that's why we always try to emphasize what these words mean. Now, there are many causes of anemia. There are many causes of polycythemia. But one of the common causes of polycythemia that's not a pathology, not a disease, is you will see anybody who lives at higher elevations or altitudes has some degree of polycythemia. That is what the human body does to compensate when you live at higher altitudes where there's less oxygen. So anybody who lives, for example, in Denver, Colorado. Now Denver's a large city, right? Is that where you're from? Yeah. What's the altitude of Denver? Well, let me help you. It's easy. What's the nickname for Denver? The Mile High City. It's over 5,000 feet. So everybody who naturally lives in Denver has some degree of polycythemia. They produce more red blood cells than normal to compensate for the fact that there's less oxygen in the air. Those people who might be from Mexico City. Mexico City is about 7,000 feet elevation. And I had a student in my afternoon class from Bogota, Colombia. She was from, not Bogota, it was Bolivia. Bogota, Bolivia, and I think that's way over 7,000 feet. So anybody who lives at these higher elevations will have a polycythemia. That's not pathologic, that's normal.
So like when sports teams go to play in these cities, it's harder for them, right?
They purposely, athletes purposely go and they train at high altitudes to increase their number of red blood cells. In the old days, they used to remove blood cells and then just before the competition, inject themselves with those extra red blood cells they had removed to give them a greater ability to carry oxygen in their bloodstream to perform better. That was called blood doping. And that's considered illegal in competitive athletics today. But it is not illegal to train at high altitudes. And since the competitions are usually at lower elevations, if you train at high altitudes, then you come back down and run an LA marathon, you've got more red blood cells than normal. Okay, let's look on the page 1 again. On page 1, so we've talked about hematocrit or percent packed cell volume. It is normally 55% plasma, 45% cells. We've spoken of what anemia and polycythemia is. Incidentally, if you know two things, you can estimate your blood cell volume and your plasma volume. You'd say, what do you mean? Well, we know how to estimate total blood volume using the person's body weight. And then, if you take their hematocrit, that'll tell you what percent of their blood is cells. So, if you have the hematocrit and you have their total blood volume, you can estimate of their total blood volume, what's the volume of cells and what's their volume of plasma. So, if somebody is 45% cells, that's called the hematocrit, which is therefore 55% plasma, their plasma volume is 55% or 0.55 times their estimated total blood volume, which for a reference person is 5.6 liters. Now you might ask, well, why would you want to know what their blood cell volume is or their plasma volume? And the answer is, in the hospital, sometimes they administer to patients whole blood. Sometimes they administer just packed red blood cells. Ever seen that? And sometimes they just administer plasma. So it depends on what they need. So you have to have a way of evaluating what would be the normal amount of each of those. Okay, now we want to talk about the composition of blood plasma, and then we'll look at the cells. Plasma is mostly made out of water. It's about 90% water. And after water, there's various substances dissolved in that water. And the major one by weight are proteins. The normal amount of protein in our blood is 7%. 7%. Percent means grams per 100 milliliters, or grams per deciliter, means the same thing. So you should know what a normal protein level is. We know that there are lots of different proteins circulating in our bloodstream, in our plasma, and almost all of them are made by your liver, right? If you're not sure, just say liver. Now, we can analyze the different proteins that are in our plasma using a technique called electrophoresis. The word phoresis means to separate. So we can separate the different proteins using an electrical field. Has anybody done electrophoresis of proteins? All right, so you can do proteins. It works the same way, and DNA. It is a common technique used in biochemistry and clinical labs to separate different constituents of proteins and nucleic acids. If you look on the next page, on the bottom right, this is basically showing you an electrophoresis setup. Here we have an electrical current. We can either use a transformer or a battery, doesn't matter. And all we're going to do is put a sample of plasma right here. Now, remember, do we know how to separate plasma from whole blood? Centrifuging, right? That separates the cells from the plasma. Then we take the plasma, put some plasma, which is water and various chemicals dissolved in the water, most of which are proteins, and then we turn on the electrical current. This is the positive terminal, this is the negative terminal. And the proteins start migrating towards the positive terminal. That should make sense. Some of you are saying, why? Because a long time ago, we learned that the major source of negative charges inside of a cell were negatively polarized proteins inside the cell. Most proteins have a negative polarity. All right, so because they have a negative polarity, they are attracted to the positive electrode, the positive terminal. Now, these proteins start to move or migrate in this electrical field. Some move faster than others. There are many factors that affect the rate of movement. One learns this in biochemistry courses. One of the most important factors that affects how quickly the proteins move is the molecular weight, the weight. What do you think? Which proteins do you think would move faster? The ones that are lighter or heavier? Lighter. Okay, it's intuitive. If they weigh less, they migrate faster. So, because these proteins are going to migrate or move at different rates, that separates the proteins into different groupings. So here, we see, this is what it would look like. And where we've separated the proteins, some have moved barely at all, some have moved a great deal in this electric field. When we analyze these proteins, the proteins that move the most, the fastest, is albumin. Albumin. That moves the fastest, and the reason why is because it's the smallest. It has the lowest molecular weight, so it moves at the fastest rate. And then there's these clusters or groups of other proteins, and they are referred to as alpha-1 globulins, alpha-2 globulins, beta globulins, and gamma globulins. In each cluster, now the word globulin just means protein. Globin or globulin means protein. So these are clusters of many types of proteins. That's not the name of a protein. Those are clusters of groups of proteins. Albumin is a specific protein. So we can analyze these proteins that are in the alpha-1, alpha-2, beta, and gamma globulin group. In fact, if we jump ahead to page 4, if you look at page 4, so there is a chart on page 4, and on this chart, and this is just a very simplified chart, I might point out, but here you can see where it says alpha-1 globulins, and it lists a number of alpha-1 globulins, including one that we're going to talk about that I put an arrow called HDL. It lists alpha-2 globulins. It lists beta globulins, including a couple that we're going to talk about, transferrin and LDL. And the immunoglobulins are also known as the gamma globulins. We'll talk about these. So these, there are books in serology or hematology that list hundreds of proteins in each group, in each cluster. There are hundreds of alpha-1 globulins and hundreds of alpha-2 and beta, and they've analyzed what all these different proteins do, and they can measure them. Let's go back to page 3. On the previous page 3, backside, so the majority of proteins in our blood, in our plasma, are albumin. Albumin accounts for 60%, more than half of all the proteins. They are, of course, like most proteins, made in our liver. And we had learned a while ago that the proteins in our blood, at the level of our capillaries, osmotically draw water, tissue fluid, water from our tissues back into our bloodstream. Since the major protein in our blood is albumin, that's its major function. So we wrote that the albumin concentration affects the colloid osmotic pressure, and that affects the amount of water that's osmotically drawn back into the bloodstream. Remember those two opposing forces? The capillary blood pressure forces water to squirt out, and the proteins in our blood, most of which are albumin, osmotically draw water in. So they will measure the albumin levels, and if those albumin levels become lower than normal, they know that that's going to lead to edema, because there won't be the normal amount of water being drawn back into the bloodstream. Now, below that, the globulins. So there's the alpha globulins and the beta globulins, gamma globulins. The globulins account for 35% of the plasma proteins. The alpha and beta globulins are primarily proteins involved in the transporting of fats and certain minerals in the bloodstream. Now you might ask, why do you need proteins to transport or carry fats, for example, in the bloodstream? Let me ask you this. Do fats dissolve in water? No. Plasma is 90% water. Fats can't dissolve in water. So the only way that fats can be moved in the bloodstream is they are attached to proteins, and the proteins basically carry them in the bloodstream. So all the fats, whether they are fatty acids, whether they are cholesterol, whatever type of fats they are, they usually have to be attached or bound to a protein. These proteins that transport fats are known as lipoproteins. Lipo or lipoproteins. Proteins that transport a fat. I'm going to give you two examples of this, two really important ones. There is an alpha globulin called HDL, high density lipoprotein. There is a beta globulin called LDL, low density lipoprotein. There are a whole bunch of these lipoproteins. Interestingly, both the HDL and the LDL are both involved in transporting cholesterol. They're both involved in transporting cholesterol. To help us understand this better, look on the next page, backside, page 4, on the bottom. Now, let me put this in the context that some of you have heard this. You have sometimes read or heard the following expression: good and bad cholesterol. You ever heard that? That's not worded right. Cholesterol is cholesterol. There's not good cholesterol and there's not bad cholesterol. But there is a good and bad lipoprotein that transports cholesterol. Now, your liver makes most of these proteins in our blood, including the lipoproteins. So one of the lipoproteins that is made by your liver is called LDL, low-density lipoprotein. That was written on the previous page. It's also listed right here on the legend at the right. Now, it transports cholesterol from the liver to the walls of the arteries. Now, we know that, in fact, your liver stores all kinds of stuff. It stores sugars as glycogen, it stores proteins, it stores vitamins and minerals, it actually stores cholesterol and other fats. In fact, your liver can even manufacture cholesterol out of saturated fats. Because remember, the way that Lipitor and the other statin drugs work is they inhibit the conversion of saturated fats into cholesterol. We learned that back in section A. So, there's lots of cholesterol in your liver, and this LDL transports the cholesterol to the walls of our artery. Now, our first thought is, why is there such a protein to transport cholesterol to the walls of our arteries? Let's remember that cholesterol in and of itself is not bad. Too much cholesterol is bad. In fact, you cannot live without cholesterol. Nobody wants you to have zero cholesterol. We don't want it to be higher than 200 milligrams per deciliter in your blood, but nobody wants it to be zero. You will die. Cholesterol is used by cells to manufacture steroid hormones, and in fact, even though I didn't talk about it, remember how we learned that cell membranes are mostly a phospholipid bilayer? But in fact, there's cholesterol in the cell membrane. All cell membranes have cholesterol in them. So it's not, you can't live without it. So there's nothing wrong with having a lipoprotein transport cholesterol from the liver, where it tends to be stored, to the other tissues of the body, including the blood vessels. We just don't want to have too much cholesterol going to the walls of the arteries. So what they do is they measure the LDL level. If your low-density lipoprotein level is higher than normal, that means you're going to transport excessive amounts of cholesterol to the walls of your artery. So they will commonly call that, quote, the bad cholesterol. It's not cholesterol that's bad, it's too much of the LDL lipoprotein. Now, why would somebody have too much LDL? The amount of LDL you make is genetically determined. It's determined by your genetics. And there are people who simply produce high levels of LDL. They didn't do what I suggested many times: choose your parents wisely. All right? Some people are lucky, they've got low LDL levels, and so they never tend to develop atherosclerosis no matter how much fat and cholesterol they eat. Now, interestingly, your liver also makes another lipoprotein that transports cholesterol called HDL. HDL, high-density lipoprotein, is released into the bloodstream, and interestingly, what does it do? It actually goes out to the walls of the arteries and transports the cholesterol back to the liver. Now, there should normally be a balance between how much LDL and HDL you have. You shouldn't have excessively high amounts of LDL, and if anything, it would be better to have high amounts of the HDL. Since HDL actually carries cholesterol from the walls of your arteries back to the liver, that's called the good cholesterol, or the healthy one. Because if you've got higher than normal HDL levels, that tends to prevent the buildup of atherosclerosis. So doctors actually measure both LDL and HDL levels. They really want, there's normal values for all of this. I'm not going to ask you to know this, but this comes from the Heart Association. The optimal level, you don't have to know this, is the LDL level should be less than 100 milligrams per deciliter. That's the LDL. The HDL should be preferably greater than 60 milligrams per deciliter, and your total cholesterol should be less than 200. So they measure all this junk, and that's the way of evaluating your risk of developing atherosclerosis. So they are trying to develop drugs that lower the LDL, the bad one, and raise the good one, the HDL. The way you can remember it, LDL, low-density lipoprotein, is the lethal one if you have too much. HDL is the healthy one, the high-density lipoprotein. Does that clarify the so-called, quote, good and bad cholesterol? It's really the lipoproteins that are transporting cholesterol. Okay, so back where we were on page 3. On page 3, so we've mentioned two very important proteins that transport specifically cholesterol. Now we mentioned that some of these alpha and beta globulins transport not only fats, but some transport minerals. I'm going to ask you to know one of them, and I'll mention a second, but I won't ask you to know it. There is a beta globulin called transferrin. This is a transport protein made by your liver that transports iron in your bloodstream. It's easy to remember. Fe is ferrous or ferric. So transferrin transports iron. In fact, if you look on page 4, you'll notice on our chart, not only does it mention transferrin, which is involved in iron transport, but another one that I'll mention, but I won't ask you to know, there is an alpha-1 globulin called ceruloplasmin that transports what? Copper. So a lot of these minerals are actually transported by proteins in our bloodstream, just as these proteins transport fats. So there's a whole bunch of these things that they can measure. I will tell you more about transferrin in a little bit. Back on page 3. Now, the gamma globulins. The gamma globulins is a cluster of proteins that you know better by the name antibodies, or if you've had a microclass, immunoglobulins. Now, remember how we've said that almost all the proteins in our bloodstream are made by our liver? Well, the major exception to that are these guys. The gamma globulins, or immunoglobulins, or antibodies, we use all three words interchangeably, these are proteins made by your lymphocyte white blood cells. Now, there are different types of lymphocytes. You learn about this in micro. Specifically, the lymphocytes that produce the antibodies are the B lymphocytes. And the way I always remember that is the antibodies are produced by the B lymphocytes. So, anyhow, in micro they call them immunoglobulins. If you look on page 4 again, on page 4, so the immunoglobulins, or gamma globulins, or antibodies, there are actually 5 classes of antibodies. And if you had micro, they should have covered all 5 classes when they were covering immunology. They are called immunoglobulin class A, D, E, G, and M. Now, this is not micro. I'm not trying to do what you learned in micro, because I'm down to a few hours, and they probably spent a couple of weeks or more on immunology. But I am going to ask you to remember what 2 of the classes of antibodies or immunoglobulins do. The IgGs and the IgEs. Now, interestingly, immunoglobulin class G, that's what we have the most of. Most of our antibodies are IgG antibodies. And the other class I want you to know are the IgE antibodies. Interestingly, those are the ones you have the least of, just trace amounts, really minute amounts of IgE. What are these 2 categories of antibodies for? If you look back on the previous page, 3, the IgG antibodies, the ones you have the most of, are the antibodies that attack bacteria and viruses. That's most of our antibodies are IgGs, that defend us against bacteria. The IgE antibodies, interestingly, are those antibodies produced against allergens, things you're allergic to. Now, there are some of you in this class who don't have any allergies. So your IgE antibody levels are really, really low. And then there's some others of us, including me, who have lots of allergies. So anybody who has lots of allergies, and any time they are actually in the midst of having an allergic reaction, whether it's hay fever or any other allergic reaction, then their IgE antibody levels go up. So they will measure the IgE antibodies as an indication of whether their person is having an allergic reaction. Okay, now on page 5, there are blood clotting proteins. We're just going to mention them now, and then I'll have more to say about them in just a little bit. They account for about 5% of your plasma proteins. Where do you think they are made? The liver. Remember, if you're not sure, just say liver. Almost all proteins are made in your liver. I just told you the one major exception are the antibodies, which are made by B lymphocytes. Now, these blood clotting proteins, and there are a whole bunch of them, include prothrombin and fibrinogen and a whole bunch of others, and I will tell you more about them very shortly. Now, we've heard what whole blood is, and we know what plasma is. If we take whole blood and we centrifuge it, that separates whole blood into packed cells and plasma. But what is serum? Serum is plasma minus the blood clotting proteins, minus the blood clotting factors or proteins. Now, in fact, if you were to take, let's say you take blood and you centrifuge it, and now you separate it into packed cells and plasma. If you pour off the plasma and just put it in a beaker, any plasma in a glass beaker will spontaneously form a clot right on the surface. And literally you could just scoop that clot right off. That was all the clotting factors, all the clotting proteins. So what's left is called serum. Now there is certain advantages of using serum in the hospital setting. Anytime you give whole blood or you give plasma, you can get blood clots because it's got clotting factors. So in fact, if you have a patient on IV drip, either receiving whole blood or plasma, they constantly have to keep infusing heparin as an anticoagulant which prevents blood clots from forming. So they're always, is that right? Always flushing the line, the IV drip line, with heparin to prevent these blood clots. If you give serum, you don't have to do it, because serum doesn't have any blood clotting factors and therefore cannot form clots in the IV drip line, so it doesn't get blocked. That's one of the advantages. Now, what is hemophilia? Hemophilia is a genetic inability to make one or more of these blood clotting proteins. Since there are many blood clotting proteins, that means there are different types of hemophilia, depending upon which of the blood clotting proteins you're not able to genetically manufacture. Interestingly, most hemophiliacs are males. And the reason why is because the genes that determine the ability to make these blood clotting proteins are carried on the X sex chromosome. That was exactly where, you'll recall, the genetic information for whether you can see in color or not are found on the X sex chromosome. So that's why not only is color blindness more common in males than females, so is hemophilia, or the Bleeder's disease. And they're different types. All right, so now, in addition to these proteins that are in your plasma, what else is in your plasma? Everything else. You got sugar in your bloodstream, in the plasma. And I do want you to know, for the final, that a normal glucose level in your blood is about 100 milligrams %, or 100 milligrams per deciliter. Means the same thing. There's really a normal range, but I would at least like you to remember this nice round number of 100. Obviously, they measure that blood sugar level. If it's significantly lower than normal, you are hypoglycemic. If your blood sugar level is significantly greater than normal, you have hyperglycemia, which might be indicative of diabetes. You have all kinds of amino acids in your bloodstream, fatty acids, cholesterol. Now, we know fats are transported attached to proteins, but anyway. The normal cholesterol level should be below 200 milligrams per deciliter. If it exceeds that, you're at increased risk of atherosclerosis. We also have all these hormones in our bloodstream. The hormone levels, though, the levels of hormones are really, really small, and they are measured in micrograms, millions of a gram, not milligrams, but the micrograms, millions of a gram, rather than thousands of a gram. And these hormones include what we've just been tested on: thyroxine, T4, TSH, cortisol, growth hormone, estrogen, FSH, LH, parathyroid hormone, calcitonin, renin, aldosterone. All these different hormones are circulating in our bloodstream, and they can measure these using a technique called radioimmunoassay. There are also waste products circulating in our bloodstream. Now, ammonia, NH3, and urea, those waste products are formed from the deamination of amino acids, largely by our liver. We know that whenever we're breaking down proteins, they're first broken apart into amino acids, and then the amino group is removed, forming ammonia, and the liver converts the ammonia largely into urea. They are re-released into the bloodstream. When they measure the urea levels in your blood, they call that the BUN level. Anybody remember what that means? BUN? Blood urea nitrogen level. That's the urea nitrogen in our blood. And then our kidneys excrete it, as well as ammonia. Now, another waste product we learned, we covered all these in section B, incidentally, is uric acid. Uric acid is a waste product formed from the breakdown of nucleic acids. So nucleotides are converted into a waste product called uric acid. Back in section B, when you review your notes, you'll recall that we mentioned that if somebody has higher than normal levels of uric acid, called hyperuricemia, that's the cause of the disorder known as gout or gouty arthritis. So you've heard of it. It's caused by elevated uric acid levels. Another waste product, because of time constraints, we really can't say much about it, is creatinine. Creatinine is a waste product formed in our muscles, in our muscle tissue. So in fact, these are the big three: urea, uric acid, and creatinine. Those are the three major waste products that circulate in our blood and that are excreted in our urine. They can measure them at the levels in our bloodstream. They can measure the levels in our urine to see if they're within the normal range. Now, another chemical that's found in our blood is bilirubin. And in fact, if we get too much bilirubin in our bloodstream, that would be called hyperbilirubinemia. Hyperbilirubinemia. And bilirubin is kind of a greenish yellow chemical, colored chemical, and when you have too much of it, it creates a condition known as jaundice, yellowing of the body because of excessive bilirubin. I will tell you more about bilirubin very shortly. Now, in addition to these organic chemicals, and that's what this was listed as, organic, there are minerals or electrolytes. And among the most important, the major electrolyte in our blood and other extracellular fluids is sodium ions. The normal sodium level is about 100 milliequivalents per liter in our extracellular fluids, be they blood plasma, cerebrospinal fluid, tissue fluid, or whatever. There is low levels of potassium in our extracellular fluids, including blood plasma. The normal potassium level is approximately 5 milliequivalents per liter. Actually, a more accurate number to learn would be 4 milliequivalents per liter, but I made it 5 just because it's easy to remember, but 4 is a much better number to learn. We know how important sodium and potassium are in affecting membrane potentials and action potentials. And we've even learned what regulates our sodium and potassium electrolyte levels. They are regulated by the renin, angiotensin, aldosterone homeostatic reflex. See how much we've learned? A lot. How much of any of this stuff would you have understood at the beginning of this course? Not too much. Okay, so calcium. We know that calcium, I'm not asking you to remember the amount of calcium in our blood, but calcium we know is very important for muscle contraction and blood clotting. And we even know that the role of parathyroid hormone and calcitonin in regulating our calcium levels in our blood. Bicarbonate, HCO3, is a buffer. It is the major buffer in our extracellular fluids that is important in buffering against excess acidity or alkalinity. And we may have more to say about that by Thursday. Okay, now let's summarize what we've just covered by looking at this chart on the top of page 6. So on the top of page 6, what it shows is this. On the left-hand side, it says whole blood. Whole blood, we can centrifuge it and separate it into plasma and cells. In this chart, they call the cells formed elements, and we know that the cells or formed elements comprise about 45% of the whole blood. The rest is plasma. I know you're thinking, why didn't they write the plasma on top and the cells on the bottom, since when you centrifuge it, it's the plasma. I don't know, but they separated this on the chart. Plasma makes up the remaining 55% of the whole blood. Let's analyze plasma. What is plasma mostly made of? Mostly water. And then there's what's dissolved in that water. Those are called solutes. If we analyze the solutes, the major solute dissolved in the water of the plasma are proteins, at least by weight. And the normal protein level in our blood is 7%, 7 grams of protein per 100 milliliters of blood. Let's analyze those proteins. We can separate the proteins using a technique called electrophoresis. And we separated them into albumin, alpha and beta globulins, and gamma globulins, and blood clotting proteins. Most of the proteins are albumin. They make up 60% of the protein is albumin. It's needed for maintaining colloid osmotic pressure. Alpha and beta globulins are important in transporting fats, including cholesterol, and also certain minerals, including iron. And then there's the gamma globulins, which are made by the B lymphocytes, which are also known as antibodies. And then there's the blood clotting proteins that we'll have more to say about, including fibrinogen and prothrombin. All right, that's a summary of what we just covered. Now, what we next want to look at is the cells in our blood. Now, there are 3 major kinds of formed elements or cells. The most of our cells are red blood cells, RBCs. We will be learning that the normal red blood cell count is about 5 million red blood cells per cubic millimeter. 5 times 10 to the 6th, which is 5 million per cubic millimeter. And in case there's any doubt, you want us to know that? Yes, because one of the most common things they check on a patient is their red blood cell count. You should know what a normal value is. Then we know there's white blood cells. We have just a fraction of the number of white blood cells that we do of red blood cells. We express the white blood cell count by thousands rather than millions. The normal white blood cell count is approximately 7 times 10 to the 3rd, that's 7,000 white blood cells per cubic millimeter of blood. So notice we measure the red blood cells by the millions rather than the thousands. And then the platelets. I'm not going to ask you to remember a number for the platelets, but blood platelets we know also are known as thrombocytes that play a key role in blood clotting that we'll be reviewing. Let's analyze our red blood cells first. Look on page 7. On page 7. So on page 7, red blood cells, RBCs, also known as erythrocytes. Red blood cells are essentially among the smallest cells in our body. They are only 8 micrometers in diameter. Now, I'm not going to ask you to remember they're 8 micrometers, but I want to impress upon you how small red blood cells are. There's only one human cell smaller than a red blood cell, and that's sperm. So they are second in size only just to the sperm in smallness. A normal cell in our body, a typical liver cell or pancreas cell or kidney cell is 100 micrometers in diameter. Red blood cells are 8. They're less than 1/10 the size of a typical cell. The reason why they're so small is so they can squeeze through these little narrow capillaries. If they were larger, they couldn't move through those tiny capillaries. But there's another problem. Because they're so small, so they can squeeze through these blood cells, they don't have a nucleus. They are the only cells in our body that have no nucleus. We wrote that right here. Because if they had a nucleus, the nucleus would take up the entire small cell, because it's so small. The nucleus would fill it up, and therefore it would not have any space to transport oxygen. So, while red blood cells, when they form in your bone marrow, start out with a nucleus, before they are released into your bloodstream, the nucleus breaks down. So normal circulating red blood cells have no nucleus in them. Because they have no nucleus, they have no genetic information, so they can't repair themselves if they're injured. Because they have no nucleus, and therefore no genetic information, and cannot repair themselves, they only live 4 months, 120 days. So we are constantly making new red blood cells in our bone marrow to take the place of those that are constantly dying. So because they only live 4 months, 120 days. Try to explain why all this works this way. Now, where are most of our red blood cells made? Most of them are made in our vertebral column, our sternums, and our ribs, our rib cage. If you look on the previous page, page 6, at the bottom, those of you who had me for anatomy will recognize this chart. It was on page E1 of my anatomy lecture outline. And you can go back and check. But anyhow, this basically is showing right here, this is showing before birth, or as you can see at the top, it says prenatal, and to the right of this dashed line, postnatal, after birth. So it's showing birth, 10 years, 20 years, 30 years, 40 years, 50 years old, 60, 70 years old. You'll notice that while your femur and tibia, the large bones, the long bones of your upper and lower leg, did produce a lot of red blood cells before birth and even during childhood, by the time you're 20 or 30 years old, can everybody see that the lines labeled femur and tibia point to 0? So, in fact, by the time you're 25 or 30 years old, the marrow cavity in your femur, your thigh bone, is filled with fat. Remember in anatomy you learned that if the marrow cavity is actively producing red blood cells, it's called red marrow, and if it's just filled with fat, it's called yellow marrow. So this marrow cavity in your leg bones is basically yellow marrow. It's no longer producing blood cells. The bones that produce the majority of our red blood cells through our adult years, are our vertebral column, which does include our sacrum and our pelvis, and the rib cage. Those are the bloody bones of our body that produce most of our blood cells. Okay, now back on page 7. On page 7, a really important subject that you have to know before you leave this course is blood typing. Because you're going to work in the hospital and patients are going to be given blood, and there's all this type A Rh positive and O Rh negative, and you have to know what that means. Now, these are really referring to antigens or proteins on the surface of red blood cells. You will remember back in section B, when we learned about the cell membrane, we learned that there are proteins in the cell membrane of cells that act as recognition sites, that allow our white blood cells to recognize which cells are ours and which cells are foreign, that are not ours. These are known as cell identity markers, recognition sites, or major histocompatibility complex proteins. Again, the MHCs. They go by all 3 of those names. We talked about them near the end of section B. So that's really what these are referring to. Now, in micro, you may have learned that the recognition sites that are on red blood cells and certain other cells of our body are different than the recognition sites found on most other cells of the body. They call them MHC class 1 and MHC class 2. I'm not going to ask you to know that, but some of you might remember most cells have what are called major histocompatibility complex class 1 recognition sites, but red blood cells and some others have MHC class 2. So these are special recognition sites on our red blood cells. There are two major groups of these recognition sites. There's the ABO group and the RH group. There are really more than that, but these are the two major ones. On the ABO group, there is something called an A protein and a B protein, and if you don't have the A protein and you don't have the B protein, we say you're O. You know what O means? 0 for A or B. You don't have it. You're 0 for that. The other group is the Rh protein, and you're either positive for the Rh protein or negative. Incidentally, 80% of the population is Rh positive. So the majority of people, more than 80, probably 85% really, are Rh positive. To help you understand this, all right, so it's got the A protein, but it's negative for Rh, so it's type A Rh negative. Let's look at this one. This one doesn't have the A or the B protein, so it's 0 or O for A and B, but it does have the Rh protein. So it's type O Rh positive. You got the idea? So it's just basically describing. So it's either got the A protein or the B protein or both, or it doesn't have either, then it's O, 0, and it either has the Rh protein or doesn't. Now there's an interesting thing about our immune system. In micro, you learn that normally you have to be exposed to something that's foreign to your body in order for your immune system to produce antibodies against it. There's one major exception. You naturally produce antibodies against whatever your type of red blood cells you're not, even without ever being exposed to it. So in other words, let's start with this. In this case, this person has the A protein, so they're not going to produce A antibodies, are they? If they produced A antibodies, they would attack their own red blood cells. We don't want that. If that happened, that's called an autoimmune disease. It has the B protein, so it's not going to produce the B antibodies. It has the Rh protein, so it's not going to produce the Rh antibodies. So this person doesn't have antibodies against red blood cells. It's commonly known, I'm not going to test you on this, commonly known as the universal recipient. It can take any blood because it doesn't produce antibodies against any of the red blood cells. Look at this one though. This one doesn't have the A protein, so it produces A antibodies. It doesn't have the B protein, so it produces B antibodies. It doesn't have the Rh protein, so it produces Rh antibodies. So people who are type O Rh negative produce antibodies against type A blood, type B blood, and Rh positive blood. Everybody follow that? So whatever you're not, that's what you produce antibodies against. You don't produce antibodies against yourself. Now, where this comes into play, very interestingly, and I won't dwell too much on it, is the interesting case of a woman, a pregnant woman, who is Rh negative and has a baby developing within her that's Rh positive. If she's Rh negative, since she doesn't have the Rh protein, she produces the antibody against the Rh protein. Now, most people are Rh positive, so only 15–20% of the population is Rh negative. That's somewhat rare. And you might ask, well, why would she have a child growing in her who's Rh positive? Because the father's Rh positive. All right, so a woman who is Rh negative produces Rh antibodies that can attack her own baby. This is known as Rh incompatibility. And they, or technically, clinically called, you don't have to know this, erythroblastosis fetalis. And they actually have to give